during the day, or if I'm going to have an event on a Sunday, it's going to be at night.
Yeah, yeah.
Test.
But also, is it possible, I'm assuming that it's possible to pull up the conversation since they're
Yes.
recording it so people can see it at any time.
Yep.
So that would be,
Yeah, we're definitely going to do that.
yeah. And, people know.
Hello and welcome everybody. Thank you all for joining us this afternoon for this Read Up Richmond tie-in event. My name is Jen Dool. I am one of the managers with Richmond Public Library, and I want to welcome you all here to our main library today. Read Up Richmond is an annual author event that we do, and its goal is to challenge people to read differently, to read outside one's own lived experiences, and to develop an understanding of the world. The program is an opportunity for people from different walks of life to come together in the library, to learn together, to enter in a conversation with a larger community, to share the same space, making Richmond a more connected, more civil place. And so this year, our event was in the fall, where Ms. Holmes was there interviewing author Dolan Perkins Valdez, who wrote Take My Hand. Some of you may have been there, and although the novel was historical fiction, they discussed some pretty heavy topics, timely topics, such as reproductive rights, racism. The last sentence in the publisher's description of Take My Hand reads, "Because history repeats what we don't remember." And I think that that's a pretty beautiful way to illustrate what many of us do as authors, historians, librarians, advocates, and it's really why we're here today as well. So many people loved Linda Janet Holmes when we did the Read Up event that I kept hearing over and over and over again, well, when's she gonna have her own program? And so we said, we have to bring her back. We have to hear more from her and from her life's work. She's an award-winning writer, a biographer, an oral historian, a curator, and a longtime women's health and birthing justice advocate. Whew. It's a lot. She's written extensively on curated exhibits about the rich history and contribution of Black midwives. Her first book, Listen to Me Good, The Story of an Alabama Midwife, was co-authored by Margaret Charles Smith, who at the time was the oldest living traditional African-American midwife in Alabama. In 2003, she published Safe in a Midwife's Hands, Birthing Traditions from Africa to the American South, which was based on oral history she conducted with the last generation of traditional Black midwives in Alabama in the 1980s, and more recently from the stories she recorded with traditional midwives in Kenya, Ethiopia, and Ghana, and midwives from Virginia. Safe in a Midwife's Hands powerfully details the birth traditions and practices of African descent midwives across the diaspora. Her research and writing on Black midwives is influenced by her work at the University of Medicine and Dentistry of New Jersey, where she held a faculty appointment with the Nurse Midwife Education Program, and her work at the New Jersey Department of Health and Senior Services, where she served as director of the Office of Minority and Multicultural Health. So she's done a lot and knows a lot and has some really great experiences to share with you today. Today she will be interviewed by Kenda Sutton-L. Ms. Sutton-L is the founder and director of Birth in Color, a Richmond-based organization that focuses on birth and reproductive health services. She's a visionary leader and advocate for reproductive justice, and she's dedicated to transforming mental health care for Black and marginalized communities. Through Birth in Color, she drives systemic change, trains doulas, and leads policy initiatives to advance birth equity, all so incredibly important now especially. So I'd like to welcome both Linda Janet Holmes and Kenda Sutton-L here today. Thank you for joining us.
Thank you.
Just a couple housekeeping things before we get started with our program. This program will be taking place in a conversational interview type format. We want everybody to feel comfortable and kind of at home here and enjoy the time that we spend together this afternoon. We are going to have an opportunity for Q&A at the very end, so please be thinking about that while you're listening, and we'll leave the last 15 minutes or so for the Q&A. Fountain Bookstore, Andy is back there. You probably saw her on your way in. She'll be selling copies of Safe in a Midwife's Hands. Please feel free to pick a copy up, and Linda will be signing those at the end of the program. And if you need to use the restroom at any point, it's right out this way to the right before you hit the water fountains, okay? So thank you again, and with that, I will leave it to you all. Thank you.
Well, good afternoon, everyone. Thank you for sharing your Saturday afternoon with us. We are thrilled to be here to talk about Safe in a Midwife's Hands. It is an honor for me to be able to interview Miss Linda, as I've been a fan and I've read all of her books. So if you haven't picked up the others, make sure that you actually do so, because it all tells you about the history. And with today's political climate, it's definitely important to make sure that we understand like the values of midwives. You have anything to say?
I am excited that you are here because I am from New Jersey. All right. And I have been in Virginia, I guess it's maybe more than 10 years now. Initially, I was in Portsmouth, and I'm now living in Hampton. And so I thought it was very important to have someone whose feet are on the ground, an activist, in terms of I'm looking back, right, and wanted to make sure we were also looking forward and addressing concerns and needs now, which I'm hoping that we'll have enough time for the conversation afterwards as well.
You want to read?
Oh, okay, yeah. So I thought, actually, I was kind of going in that direction because I thought it might be a good way to start for you to know a little bit more about me other than, you know, the books I've written and all that kind of stuff, which has to do with my own personal birth experience. And midwives, as you may know, frequently talk, at least traditional Black midwives that I interviewed and the midwives that I interviewed in Africa as well, that midwifery was not work, it wasn't a job, it wasn't seen as a profession even, and that seems to be true even now among many midwives. But midwives in Alabama, in particular, had this term that they used, which was called a call to practice. And it could have come from a dream or a vision, so that it wasn't just an occupation, it had this spiritual connection. But it also could come from their own personal experience. And so my call to the work that I've been doing actually came from my own birth experience. And so I thought I'd read a little bit of that from the book, which is how the book begins, and it's called My Journey. When I gave birth at St. Joseph's Hospital in Paterson, New Jersey in 1976, a little bit about my age, right? I had no idea that my childbirth experience would launch a lifetime of work. 49 years later, it says 45 in the book, but it's now almost 50 years later, I remain committed to activism and write in support of a growing birthing justice movement that aims to end inequities in birthing care and outcomes. I dedicate the stories in this book to that movement. The fire I bring to this work still burns from my engagement in the 1960s Black student revolutionary movement. On the Rutgers campus, I was among the Black students who raised our fists in making demands that challenge structural racism, the abysmal lack of Black faculty, and classes focusing on Black history, and Black student underrepresentation in the student population at this state-funded institution. Preparing for giving birth 6 years later felt like readying myself for a Black Power march on campus. But this time, the demand centered on seizing the power to make choices about my own childbirth experience. To prepare for childbirth, my partner Welton Smith and I took classes with Elizabeth Bing, known as the mother of Lamaze. I took classes with her in her apartment on the Upper East Side of Manhattan. Despite my preparation and determination to have my wishes respected, doctors administered Pitocin, a drug used to stimulate labor, and ordered an epidural, a procedure that injects a local anesthesia into the mother. In an act of self-empowerment, I refused to agree to an epidural unless my partner could be in the delivery room to provide emotional support. We also convinced the labor and delivery room nurses to agree to give us champagne and keep it, not to give us the champagne, but to keep it chilled in the refrigerator for celebrations a couple of days later following the birth. That's when a nurse told me that I was the first in the hospital to request rooming in with a newborn so that I could breastfeed with ease on demand. What I didn't know then, but later learned, is that many of the best practices that Lamaze classes promote are traditions that midwives support. Remaining active during labor, being awake and aware for birthing, using alternative upright birthing positions, and creating a welcoming environment that encourages women and others to gather to provide comfort throughout the birthing process are the hallmarks of traditional midwife practices from time immemorial. The African continent, the cradle of humanity, provides some of the earliest examples of how midwives were the caretakers of rituals as well as best practices celebrating the birth event. And I'll stop there.
So that's an amazing story, and I'm thankful that you actually shared your birth experience so that people can kind of really understand the differences between the birthing experiences, but also correlate with like how it's still similar. Sometimes it's still that way where providers are still pushing what they want versus it being shared decision making. So throughout the book, you draw a powerful line between the legacy of Black midwives and today's birth justice movement. What did you discover about the erasure of midwives from the mainstream narrative of healthcare history, and why is reclaiming on history so important?
So I think for me, it was visiting a friend in Alabama, Selma, Alabama, at a time when I was working with a nurse midwife program at a medical school. And at the nurse midwife program in the medical school, I learned that midwifery care was being provided to women who didn't have other options. It was seen as a way to care for women who might have lacked Medicaid or who were unable to have insurance. And so midwives were seen as the way for poor women, underserved women, to receive care. After my own birth experience, I actually kind of stepped back and I got a master's degree from Rutgers in public administration. But my focus the entire time was on women's health and midwives, right? This is now in the 1970s. By the way, my daughter lives in Hampton and she's almost 50, just to give you some perspective again about the history, right? But when I was doing my research at Rutgers, everything I could do to bring in the midwifery history, the regulations surrounding midwifery, I took an opportunity to do that. But one of the things that I did was to go and meet with the person who was the chair of the Department of Obstetrics and Gynecology at the medical school in New Jersey, Dr. Kamenetsky. And he greeted me as a student, graduate student wanting to do this survey with women who were using the midwifery care there at the medical school. And I said to him, I have this, survey questions that I would like to ask. For example, would there be women who would like to have their partner with them at the time of birth? Were there women who wanted to have minimal use of drugs? Were there women who wanted to breastfeed, and so on? And I think I can do this. Okay, so he looked at my survey and he did the following. He said, "You don't understand." He said, "The women here, they're not interested in that kind of thing. That's something, for middle-class women who have insurance and so forth and so on. These women, they're on. You have to remind me what the question is, by the way. Okay. they're on drugs and so forth. This is the last area of choice for these women. This particular doctor, who I later developed an ability to have conversations with when I was working with the nurse midwifery program. This particular doctor ended up being in charge of public relations for ACOG several years later. Remind me of the question.
Oh, you're on the right path.
Okay.
Throughout the book, you draw a powerful line between the legacy of Black midwives and today's birth justice movement. What did you discover about the erasure of midwives from the mainstream narrative of healthcare history, and why is reclaiming that history so important?
Right, okay, so I want to focus now on reclaiming the history and why it's so important. Because I learned when I was in Alabama how respected, kind of like the flip side of what Dr. Kamenetsky was saying, Black midwives were. My friend said when she was living in New Jersey that whenever she came home, she would always make a point to visit the midwife. The midwife was honored. The midwife was respected not just as a birth attendant, but as someone who provided holistic care, as someone who had strong relationships with the family and the community. They were not just seen as someone who they met for the first time when they were delivering their baby, which frequently happens still in hospital settings. So the idea for this book was that in order to move forward, in order to find a path that would open more doors to midwifery and the kind of care that women, regardless of their class, regardless of their economic group, regardless of their race, are interested in, was this idea of Sankofa. The importance of looking back to see what lessons can be learned that can apply to the many challenges that we see today.
Thank you so much for that. A part of the story, you said like how he ripped up your survey questions. And that still happens today when people are putting OBs and it's like midwives have to struggle to be recognized. But we know when we look at the numbers that midwifery care shows so much better outcomes than OBGYN care. And so one of the things in Virginia, when we talk about our Virginia task force and measuring those data outcomes, there's no way to measure the midwife outcomes, and they're not even focused on that. And so a lot of times we're asking, like, why don't you have a checkbox for midwives? Why is this not paying attention? And Virginia, we've come so far, but we still have so much more to go as far as the legislation and just making sure that midwives do have autonomous practice in Virginia. And so that's really, really important that you highlighted that piece. People do really need to know that. And so you highlight the systemic efforts to delegitimize midwifery, particularly through policy and regulation. How do you think this historical targeting of midwives, especially Black midwives, continues to shape maternal health outcomes today?
Well, I guess the first issue is that there aren't enough midwives, period, in practice, right? There are not enough midwives of color, there are not enough Black midwives. And it's important to remember, because my focus has been on the history, right? So up until really very recently, everyone born, everyone who got here came through the hands of a midwife. And since I was in Virginia, I became aware of, Jefferson had there were midwives there who attended the majority of the African Americans, but they also attended enslaved women, but they also attended white women, right? Because they knew that they were the quality care deliverers of maternal and child health, so that they were viewed even by Jefferson and George Washington, and I can't recall the names, but their names can be called, and some of them were paid. So enslaved women being, talking about the difference between now and then, right? Being valued so much that as enslaved women, they were actually paid a certain amount of money. It probably wasn't a lot of money, but for their services. I was recently in California and learned about a phenomenal midwife, Biddy Mason, who, she was enslaved in Mississippi and walked to California, and later became recognized as a midwife as a result of going to court and so forth and so on. Her story is phenomenal. She became, in terms of dollars, before she died, by translating dollars into dollars now, she was a millionaire. She had her own home. She helped to she was the founder of the first Methodist AME church in Los Angeles. The other incredible thing is that I just happened to be looking through the New York Times one day, very recently, a couple years ago, and there was this mural, and her image is in the painting because she is there assisting a doctor doing surgery in San Francisco. And this was one of the most renowned doctors in California at the time, but he wanted someone to assist him in not attending a childbirth because he trusted her and he recognized her skills, right? And this is, we're talking about the 1800s. And so up until very, very recently, like yesterday, and even at the point when they passed the laws, which I could talk a little bit more about that, saying, no more midwives, et cetera, et cetera, et cetera, and doctors kind of taking over, right? Many of the black midwives in Alabama and across the South, where black midwives continued their practices the longest, those women continued to care oftentimes for white women who were wanting to have a home birth, right? And there were not a significant number of lay midwives outside of the black midwifery community. So certainly that was true in Alabama and in many places in the South. And I have this tendency to talk a lot because I get really excited about making the case for midwives. I think it was unfortunate that I think for the black community at one point, there was this sense that midwifery care was the only birthing care accessible to us, right? And that due to racism, white supremacy, et cetera, the doors of hospitals, and again, most women did not give birth in hospitals until the 20s, this is all new stuff, right? But black women and families did not have access to hospitals. And so when the civil rights movement comes along and says, there needs to be equity, there needs to be justice, that I think that in some ways, for the black community, the concern was the fight, a justified and needed fight to open up the doors of schools, courtrooms, to equity, right? And so in some ways it eased or kind of blinded some folks in terms of thinking hospital care, medical care was somehow led to better outcomes than a care from a black midwife, community-based, having attended, like Margaret Charles Smith and others that I talked about, hundreds and sometimes thousands, never having lost a baby.
And that's important that you bring that piece up because in Virginia, Mama Claudine Smith, who's from the Northern Neck, she delivered over 500 babies, never lost a baby, had great collaboration care with OBGYN. So if it did need to be surgery, it was correlated and talked about. And so when you think about those outcomes and how the structure between, you know, the Department of Public Health, who put all these regulations on midwives, community midwives, what are your complete thoughts about that? Because when we talk about midwifery care now for our community, sometimes it's still like they don't understand that it's not that the hospitals are better. Or provide better care. This is what our families have done for trillions of years, and it just seems as if that education isn't out there for people to really truly know, like, birthing at home is safe. They do risk factors, they do all of those things, and how that's why, you know, it's not as many Black midwives, because even her, she said, and she has a book out as well that she talks about, once they put all these regulations on, no one wanted to continue to like pay these fees or be under this microscope of care that they portrayed as like, oh, we're doing this for you, but they really learned everything from the Black midwives.
Yeah, it's complicated, right? So there are women who, based on risk factors, who may need medical care. But we also know that there are issues about the quality of medical care that's often received in hospitals. And I think Beyonce and others have really made the case that even if you have wealth,
Yes.
that, and even if you have a need to be in the hospital, that sometimes it doesn't deliver well. One of the women that I interviewed did her medical education at the University of Virginia, but she's not in the, she's in the book, but she doesn't tell the story, and I didn't use the story in the book. But she was talking about the fact that when she was having her baby, and she was on a fellowship, she was quite recognized as a physician, and when she was having her baby, the decision about, well, you know, is it going to be a cesarean or can she deliver the baby naturally? And it was so interesting because she told me that she was a fellow in the medical setting, and so these were her peers, right, who were having the conference on the side about this woman needs a cesarean, this person now needs a cesarean section. And so she, in the midst of labor, you know, wanted to have that debate, like, you know, let's talk about this. Now, meanwhile, her husband, of course, is concerned, right? So he's really concerned. But what she said that was so interesting to me was that in the course of the conversation, she was no longer an expert. She was no longer a peer physician who had the information to have this conversation about whether it was appropriate, whether we should give labor a little more time or not. And she said, and this was the direct quote, she said, at that point, I knew what it felt like. You know, imagine being poor, imagine being Black, imagine being an immigrant and not speaking the language. How, you know, how do you raise those issues and those questions? So I think as we continue to focus on, and I agree with you, as we continue to focus on midwifery care, we also have to focus on, because we know that there are times when the medical intervention matters, but if there's if the communication, if there's, the one about, that's the University of Virginia study, Black women can tolerate pain much better than, you know.
Yes.
So all of those issues are influencing the quality of the medical care that's received by Black women and by other women when they are seeking care in the hospital. And I think where the problem is that a lot of women, Black women and white women and Indigenous women, do not understand what is the quality bonus of midwifery care. What are the reasons to reach out to a midwife in terms of the quality of time, the lack of misuse of or overuse of pharmaceuticals. One of the quotes that I love in here is the use of massage, right? Not just for comforting, but using massage to actually positioning the mother for, you know, the presentation that midwives and others want, which is a head first, right? So being able to turn the baby, so that midwives have these skills. Midwives in Alabama, midwives in Virginia, midwives have these skills, and having the psychological, having, you know, given birth, right? Having the psychological state of mind that midwives are expert at. And also their best practices, keeping the mother, I mean, the list is long, keeping their mother active during birth, minimizing the use of drugs, having birth being welcoming, other women, welcoming families, so that it's not an isolated experience where you're feeling like you're the patient, you're the mom giving birth. So that all of those are qualities that are frequently lacking, and they continue to be lacking in hospital-based birthing care.
So I was glad that you brought that up, because that's a great segue into our next question. A recurring theme in your book and what you've talked about earlier is trust. Trust between the midwife and the client, trust in the body, trust in ancestral knowledge. How do you think trust is built in birth spaces today, and what role do midwives play in restoring it?
Yeah. So both, the reason I went to Africa to interview midwives is because there was one of the stereotypes that was used to get rid of midwives, right, to say midwives are ignorant or they don't have the skills, was that a lot of what they did was based on superstition, right? Old wives' tales. And what I learned was that, in fact, what they came with to the birthing experience was not only skill, and this I'm talking about skills learned from their mother. Oftentimes it was a lineage, right? So that their mother was a midwife, their grandmother was a midwife. And there was also the community. Talk about the trust issue. The community was the quality assurance piece, because there were testimonies, right? There were testimonies from the women who were your neighbors, and also these midwives, they were community-based. So it wasn't like you would have to go out of town or look in a book or somewhere to find out the track record. You knew there are many, like Mrs. Margaret Charles Smith had attended close to 3,000 babies. There are many midwives that did not attend that many, anywhere near that number of babies. They were kind of like, if nobody else was there, they would catch the baby. But there were many midwives who were experienced and were well known and recognized. And they lived oftentimes in the community where they were serving women. So there was one midwife who told the story of, she had delivered a mother, and then she would have the children in her classroom as a teacher, because she was a midwife and a teacher. So that's, but she was a school principal at one point, but she was this amazing woman. But they went to church with these women. There's a story in the book about every time Chester Higgins, an incredible photographer, whose work has been shown at the at the museum. That's my friend back there, who's, well, that's a whole nother story. Sarah, be sure to talk to Sarah. But he talks about how his aunt, right, when she walked into the church, everyone stood up. Because she was not only respected as a birth attendant, she was expected as a woman who cared about the well-being of the entire community. And not just at the time of birth, but there's stories of midwives who would bring clothing or would bring food. The woman I'm talking about now that was a school teacher, she delivered triplets. And she couldn't get the doctor, this is after integration, she couldn't get the doctor to have the babies assessed in the hospital setting because they were Black, right? And transportation and all of that. She ended up going by the house to help feed the babies because they couldn't breastfeed on the way to school every day. She was also the director of the choir at the church. There was a midwife in Alabama who not too long after they eradicated all the midwifery practices, but they named a housing project after her because she was a midwife, but she also taught literacy classes. She also saw the well-being of the whole person, not just the doctor who, pops in to catch, not to catch the baby, but to quote, deliver, deliver the baby. Now again,
No, you answered the question. You did good. No, you did good. And so I was glad that you brought that up because you talked about community-based care, right? And so in some settings, there's this big difference between community-based midwives versus hospital midwives. And so when you think about that and you think about the hospitals who say like, well, if you're not a certified nurse midwife, you can't practice in my hospital. But that level of care is so different, even though they're both midwives. That community-based aspect really, truly matters in the type of care that is going to be received.
You should also share about your own midwifery heritage.
Yes. So my heritage comes from, I'm from the Northern Neck, where it's a royal community. Most people don't know where it is. And so if you drive past Tappahannock and you drive through Warsaw, Richmond County, you'll drive through Farnham, you'll get to Lancaster County, Northumberland County, and so that's originally where I'm from. And so when I referenced Mama Claudine Smith earlier, that's where I was referencing. And so she actually, my nephew is one of the last babies that she actually was able to see and like provide assistance and answer questions. And so her granddaughter, Merle, who's my nephew's grandmother, also was the one who actually provided care during the time because I couldn't provide care to my own sister. So she used all of the tools that she was taught to actually help this process as well. So my whole family comes from healthcare. And so I try not to really use it when I'm advocating because people will ask so many different questions. What about your grandmother? So Mama Claudine Smith, and so that's where this whole realm all comes through. And so as a little girl, like being a part of the people who are providing healthcare services, and like my mom, she's a nurse, and everybody. So when I look at the system and I decided like when my friends were having babies, they didn't know what to do. And so I'm the one who's giving them information. I'm the one who's providing care and saying, okay, and so this is the launch of Birth in Color. And this is why me interviewing her was so important because I want to say like 4 years ago, she actually reached out to me and was like, hey, I want to do a documentary. I want to do a story. I want to ask questions. And so even if you go to the African American Museum, while it's still here, you will see it actually references Mama Claudine Smith. And so that's where my heritage and stuff comes from. And so that's why I've been so involved in making sure that when we think about black women getting care, that it shouldn't be considered a privilege. It should be, they should receive first-class care regardless of what I look like, regardless of my background. And so what we do know that no socioeconomic status deters maternal mortality. And so that's the segue into my next question.
So I do want to say though, we have to remember that nurse midwives, right, that history is short.
Yes.
That history is also short. And when I was working at the medical school in Newark, one of the things that I came across, because nurse midwives did not want to define midwifery history as anything, like midwifery history began with nurse midwives with, in Appalachia, right? And modeled after the British system. So I thought that was rather odd. And so I tried to find some documentation about midwifery care in Newark, New Jersey, in the, prior to hospital birthing. And it was the immigrant midwives who were very prominent as care providers. But what was most interesting is that in the 1920s, in a journal article written by a physician, he argued that the immigrant midwives actually had better outcomes than the doctors, right? And these were Irish women, Italian women, and so forth, born in Europe, and were bringing their skills. I also learned, this was also coincidence, I was on a bus going to a public health association meeting, and someone had overheard me talking about midwives, and she said, well, this brings us back to the current moment. The CDC, the Center for Disease Control, recently did a study on outcomes, comparing midwife outcomes with doctors. This is in the 70s. And what they found was that, and these are not nurse midwives, these are the traditional midwives, that the study was designed so that the women received prenatal care, all the same level of prenatal care at a public health clinic. And then the women who were midwives attended the mothers at home, and then the doctors attended the mothers in the hospital. And so they were pretty much the same in terms of this study. The baseline was the same. The women were pretty equal, right? But they actually found out that the Black women, the granny midwives, not the nurse midwives, the granny midwives caring for women who received the similar prenatal care had better outcomes. CDC study. So I think, to answer your question, I think some of the concern has been, up until recently, it was the monetary battleground, right?
Yes, yes.
Not wanting to turn over birthing care. And I think that's changing a little bit, because the whole medical system, the whole technology piece might actually help to bring more
it all
attention
together and bring more attention to it. Especially because those community-based midwives are not allowed to practice in the hospital. And so now we see a lot of hospital systems and practices actually hiring and having midwifery practice. And then they're like, well, our outcomes are a little bit different. Like, what are we looking at? And it's that community-based care that is actually absent from it. And so that's why it's extremely important to, when we're talking about midwifery care, that we throw in that community-based piece, because those CPMs provide great care.
And the other thing is to not forget that it's not just the prenatal care that affects a birthing outcome or the care that you receive at the time of birth. That you have to look at the big picture, right? The issue of nutrition, access to fresh food, the whole environmental issue, the level of stress, right? And even in terms of, Nicole Wardlow, a midwife, gave a wonderful talk on the importance of mental health issues in the postpartum time. So it's very complicated, and it tends to be way too simplified, that if, a doctor who has this amount of education, you'll have a better outcome.
Right, which is very true, which is why, when I speak, I talk about from the reproductive justice framework, because we talk about the intersections of all of the things that actually have to do with maternal health outcomes. And there's this big separation between maternal health and reproductive justice or reproductive health, and it's really all the same, and all should be talked about intersectionally, and all have the same thing to do with each other.
Did we go over 5 minutes? Oh, okay. All right, so maybe a final
So the final question.
Okay.
The stories you share from midwives and birthing people are deeply intimate and affirming. How did you decide which stories to include, and what responsibility did you feel in telling them?
Well, in Alabama, I interviewed 50 midwives, and they were all tape recorded, and they are on deposit currently at Smith College in the archives there. I have had almost like lots of trauma about opening it up to the world. I'm getting better at it for several reasons. One is that when I did the interviews in 1981, the women had just been literally eradicated from history, right? Mm-hmm. And with no consideration about the number of babies they had attended, no consideration of outcomes, no consideration of need. So the fact that someone had come from New Jersey mm-hmm. to interview them I was welcomed, right? And so I've had to think a lot about the fact that they did sign consent forms that allows me to deposit their tapes where they are. And I don't know if their family members had been there, whether they would have had different thoughts about it. Now, though, I'm kind of thinking now that it is time to open up the collection mm-hmm. because there is a movement that's strong and enduring. One of the midwives said to me, "Don't you worry about those midwives." She said, "Well, there are midwives in the Bible. There are midwives, now, and there are going to be midwives in the future. Midwives aren't going anywhere." So I don't think opening up the collection will threaten right. the survival of midwifery. But it was something mm-hmm. that I had to think about because I thought about doctors or some saying they weren't medical and then using those stories against them. But my choice about, what was the specifically?
Your choice about the stories that you actually chose.
Oh, the ones that I chose. Okay, well, one, good storytellers. Mm-hmm. People who really were good storytellers. Two, women who had outcomes that were positive and could talk about that. But also, I was very interested, and that's why I went to Africa, in the traditions. Because the traditions were being dismissed as superstitions, backwards and ignorant. And that they had and that was a sign of their lack of intelligence. So even if they had positive outcomes, how could they be believing in all this crazy stuff, right? So when I went to the continent is when I learned that things like using alternative birth positions, which is good science, but if you look at the walls of the Egyptian pyramids, you see women giving birth in mm-hmm. the upright position. When I went to Ghana, people were giving birth in the upright position. Burial of the afterbirth was considered, why would you want to, burn it? When I was in Ghana, I watched the ceremony around the burial of the afterbirth, going into a clay pot, the prayers around that, the burying of it near the house, very specific traditions around that. Why are you using these wild herbs and plant medicines, and why aren't you can't? They banned them from using any traditional plants. Of course, you go to the continent, and so that was the reason for Safe in a Midwife's Hands. My first book really focused on a particular midwife and her incredible outcomes, mm-hmm. but I really wanted to, this argument that Black women were ignorant and superstitious, and the call, the prayer, mm-hmm. the spirituality was very, very, very similar. The lineage, my mother was a midwife, my grandmother was a midwife. A couple of the midwives were able to trace their midwifery lineage back to the era of enslavement. So that they were witnessing the skills, not necessarily in the birthing space, but knowing about the gardening, knowing about mm-hmm. the extended role, and continuing that tradition. I think those were some of the reasons.
Thank you so much for sharing that. I truly appreciate it.
All right, thank you both so much. Yes, we can't wait for the roll. I'd like to open up the floor for questions. We do have some people joining us virtually as well, so if they would like to ask any questions in the chat, you're welcome to do that. The microphone is actually for them, so they can hear the questions that are being asked. I'm happy to come around to you if you have something that you'd like to ask either of our speakers today.
So a friend recently asked me this, and I hear this all the time. Can you help me find an OB? And so I always want to say, what about a midwife? And the response is often, if they're not thinking about having kids, well, I don't want any kids, or I'm not thinking about kids.
I'm sorry.
I'm not thinking about having kids, so I would use an OB. So you talked with so many midwives, so I would love to hear what you would tell people who the automatic assumption is you only use a midwife if you are having kids. Based on interviews with all the midwives that you talked with, did they only work with women and birthing people who were having kids? So what would you say to all the people who, I don't need a midwife?
Are you following the question?
Because
So what would you say to someone who says, I only need GYN care, so I don't need a midwife?
Okay, I got you. All right, the only reason it took me a minute to make the shift, because in the midwives that I was interviewing, there were midwives who talked about abortion, who talked about ways to not have a baby, right? But that wasn't in my interview schedule, right? I was focusing completely on birthing care. But I think you're really addressing a more contemporary issue, right? About the scope of practice of midwives.
no, mainly just when you think of a midwife, do you think only
Do I?
for just the midwives that you talked with? Were they generally only focused on childbearing, or did they consider themselves as a healer, for the entire, community, sort of
Yes.
as the more cradle to grave kind of care?
Right.
Because I know now we think midwife is only having kids and OB is everything else. And actually, right, we don't even think midwife, we think OB is cradle to grave, and we don't know what a midwife is.
Okay, all right, so I think that the midwives that I interviewed in Alabama were definitely recognized in their community for the work that they did primarily as midwives. However, many of them were also respected as, I think I mentioned the school teacher. There was one that was a community activist, right, who they said about Thelma Schamberger, if anyone like the mayor or the council came to town, to their community, and wanted to talk about vaccinations or wanted to talk about enrolling in getting the kids into kindergarten, because the midwife was the respected, singularly respected in the community. And it didn't matter whether you went to the same church as she went to, but because they knew of her record as a midwife and being holistic as a midwife, that they trusted her opinion and her leadership, so that midwives often were recognized as leaders beyond the birthing space because they were concerned about the whole person. And then the midwife who was a teacher and a principal, so that they did have roles that extended beyond catching babies. And also, healthy, right? So you want to have a healthy baby, you want to have a healthy mom, you want to have a healthy community. So midwives were often consulted that way, but I think ultimately midwives that I interviewed who had attended a number of births certainly had a recognition that was singular about that. But I thought you were trying to get more into the contemporary issues about midwives being seen only as birth attendants, because that certainly is not the case. And midwives have really done a lot of work in the last 20 years to be seen in more spaces. And actually there's some concern about the number of midwives who are now getting PhDs and doing research and so that not losing this core piece of what traditional midwives have been about, and honoring that and respecting that and paying and getting insurance reimbursement for that as well, so, yeah.
So throughout the course of your research, have you had the opportunity to come in contact with a male nurse midwife?
I have not had the opportunity to come in touch with a male nurse, but there are male nurse midwives for sure. And the story that I told about the grandmother who used her hands to give a massage to, she actually, I thought this was interesting because her grandson was actually the one that sometimes assisted her, like if she needed something like towels or whatever, or water from the well, or kinds of things. But he said, he later became a minister, he said that his grandmother wanted him to be a doctor. And that was her dream for him. But there are male nurse midwives, but not in any significant number. And I think it's kind of like one of those, since the beginning of time, it's been a kind of a women's event. In Africa, the circle around, and even here in the United States, in the South, women gathered. So it was a time for women to be able to celebrate what they're bringing to a space as women in terms of the food, in terms of, in Ethiopia, they said that the women would come and they would chant the name Mary, right? Just chanting the name Mary, but also catching the pains of the mother that was in. So that this idea that the women were catching her pain. So there were these kinds of things that women bring. But there's also a story I heard from someone in Ethiopia about the men would, if having trouble with the birthing, that sometimes that they would tighten their belt, or they would be outside, they'd be far away, but they would do that, and men would celebrate, of course, after the birth with naming ceremonies and so forth. But I think it's wonderful. I mean, and clearly a man can have the skills and the compassion and all of the things that we're talking about. So that's not to say that only a woman could be a midwife.
Thank you. I've noticed that in midwifery, it often calls for a lot of dedication of your time. With the midwives that you interviewed in Alabama or throughout your other experiences, have you been able, what was their work-life balance, and how were they able to, I guess, adjust to that with life?
Basically, what is work-life balance like for midwives? Does it, yeah, there's a lot of investment, probably personally and professionally, for midwives. So what does that look like for them?
So for the midwives that I talk to, there is no work-life balance. And I'm the person who, I get to be with all the elder midwives. I'm fortunate in that way. And I'm always the one who's telling them self-care, like you're taking care of everybody else, but you're not taking care of yourself. And what we do know as black women is that's what we've been known to do. And so our generation is the ones that are telling midwives, like, hey, we need you to be around a little bit longer, so we need you to take a break. Let's figure out some systems to put into place so you can have a midwife that's on call for you when you want to take a slight little vacation. So they're still learning how to actually do that. I don't think any of them have really achieved it as of yet, but it's really no work-life balance. Because you spend most of your time pouring into someone's family and pouring into what they, trying to make sure that they are well equipped for this new journey that they're going to be on.
Thank you for being here and speaking to us. So you guys have taught me a lot about midwifery. Although there are probably many differences, can either of you speak on maybe the macroscopic differences and between a midwife and a doula and how they may work together?
A doula, right here.
Okay, so this was actually a question I was gonna ask her, but we ran out of time. So the difference between the midwife and the doula really is that the midwife is actually providing more of the the care as far as, okay, this is what you need to be doing, this is your nutrition, this is how we're going to do your birth, this is like, okay, you're low risk, you're high risk, we need to worry about these factors. So they're more of a medical, but midwives are medical, but they provide a different level of care, so I don't want you to think it's all medical. And so that's the difference. And so doulas are non-medical. So we provide like comfort measures. And so back in the day, there were midwives who were doulas also. And so you have a term like birth sisters. And so that's where that goes. And so the doula is non-medical. I always try to tell people we don't go to a birth if you don't have a licensed midwife with you. And licensed, I mean traditional CPM, CNM, however that scope goes, because that's the scope of a doula. We're providing education also, but the midwife also supplies education. We're doing birth plan with them, but they also take the birth plan to their providers, which is the midwives, to say, hey, this is what I came up with. Do you have any pros and cons of this? And so there's this big thing now where people are speaking on, oh, doulas and midwives, and they pair them together, but they really are totally separate. But doulas and midwives work so well together that it's like a Batman and Robin situation. And so I always like to refer to it as that, but the doula is non-medical. We don't check your cervix, we don't do blood pressure cuffs. Any science things we don't do. It's really about comfort measures, making sure you're equipped, making sure that you know what to do postpartumly, and making sure that you're actually providing that self-care aspect is more of what the doulas are.
I just want to add to that, though. There is some conversations going on about that, because I think there are midwives who also see many of the things that you're talking about as core to their practice as a midwife, right? And so there is this kind of, I think it's like this connecting, like when the midwife and the doula is there together, so it gives the midwife a chance to focus more on the process of the birthing as opposed to doing the massages and the song and the whatever. But midwives that I know also are very much committed to the spiritual, the emotional, the comforting, the listening approach that also distinguishes them from the medical model of care. And so that I think that, and also, as doctors are different, midwives are different, doulas are different. You know, so I think in terms of building the birthing team, it's really important to spend time meeting the doula, meeting the midwife, meeting the doctor, who would be the backup person if you're not having a home birth, or even if you are having a home birth. So just meeting the team, and I think doulas, though, have made a significant difference in terms of educating, the political impact doulas have had overnight. I mean, it's incredible in terms of increasing the understanding that you can have a safe, healthy, happy birth without being in an obstetrical, hospital-based medical setting.
I'm so sorry. We've reached our time. And I'm so sorry. I will encourage you all to stick around. This has been such an amazing conversation and obviously have inspired our audience. And thank you all for both being here, telling these stories. We are going to be doing a book signing afterwards, so I would encourage you, if you want to ask further questions or stick around and chat, to please do so. Both Kenda and Linda will be here for a few minutes, I believe, to do that.
This doesn't normally happen.
No, not at all. If you registered for the event today, I will be sending a follow-up email just with a brief survey on how you felt about the event. It helps us to be able to do this more in the future. We'll also be announcing our next Read Up book selection. You guys will be one of the first to know. So thank you all for coming.